All right, good afternoon, everyone. On behalf of the Hepatitis B Foundation and our Happy United Partners, co-chair the Association of Asian Pacific Community Health Organizations, thank you so much for joining today's webinar. My name is Kate Morales. I'm the Senior Program Director of the Hepatitis B Foundation, Director of the Happy United Coalition. So we're really excited to present today's webinar on screening for hepatitis B in clinical and community-based settings. We have two great presenters joining us today. But before we get started, I'd like to review a few housekeeping items and let you know how you can participate in today's webinar. Please note that you are in listen-only mode due to the volume of the audience, and you'll be muted during the presentations. There is a phone-in option, and the call-in numbers are shown on your screen. You may feel free to submit questions at any point during the presentations. You may submit them in questions by typing them in the question box on your GoToWebinar control panel. We will be reviewing them as they come in, and we'll hold a question and answer period after the presentations. And finally, today's webinar is being recorded. You will receive an email with a link to share and view a recording of today's presentation within a few days after the webinar. And so I'd like to go ahead and present both of our speakers today. Our first presenter will be Dr. Karen Kim. Dr. Kim is the director of the Center for Asian Health Equity at the University of Chicago Medicine, and she is also board president of the Asian Health Coalition based in Chicago, Illinois. And then our next presenter will be Ms. Jane Pan. She is the executive director of the Hepatitis B Initiative of Washington, D.C. So we'll start with Dr. Kim's presentation. Dr. Kim will be sharing with us a study that the Asian Health Coalition looked at comparing clinical versus non-clinical screening settings for hepatitis B. And then we will finish up with Ms. Jane Pan, who will share with us a community-based screening model. So I'll turn it over to Dr. Kim.
Thank you so much, and thank you everyone for joining us today. So I'm going to start by talking a little bit about some work that we've done in Chicago looking at hepatitis B control across clinical and non-clinical settings. Next slide, please. Oh, I think I can change it. Okay, maybe not. Okay, so just to give some background, I'm sure most of you are familiar, but just to get us on the same page, it's estimated that about 2.5 million people in the United States are chronically infected with hepatitis B. And foreign-born Asian and African individuals in the United States are really disproportionately affected by this disease. In fact, foreign-born Asians make up about 60% of those chronically infected in the United States, despite the fact that they make up only about 5 to 6% of the population. So this is a really big disproportionate burden. In fact, about 1 out of every 2 people with chronic hepatitis B in the U.S. are Asian Americans. In terms of foreign-born Africans, they account for nearly 25% of those chronically infected. And again, this is despite the fact that they make up less than 0.5% of the population. So this is, again, a disease that is disproportionately prevalent in sort of harder to reach communities, which is why it's so important to understand how to reach in and provide education and screening. Next slide, please. So in terms of morbidity and mortality, this is not a disease that doesn't leave a path of devastation. In the U.S., estimated about 1,900 people die each year from hepatitis B-related diseases. And in fact, hepatitis B is responsible for 75 to 80% of virus-associated hepatocellular carcinoma or liver cancer, compared to 10 to 20% for those infected with hepatitis C. So this is really a very highly oncogenic potential that can lead to liver cancer. And the sad thing about that is hepatitis B is a bit unique in that you do not need to have cirrhosis or hardening of the liver in order to develop liver cancer. So that's a kind of a unique pathway. About 25% of those with chronic hepatitis B will die early from complications of the disease. So again, this is a disease that we can prevent it, but unfortunately this is not something that we're seeing. Next slide. So in terms of the treatment cascade, and this is really where we have a lot of work to do. If you look at the number of individuals infected with hepatitis B on the left, there's again about 2 million, 2.5 million people infected. But unfortunately, if you look at the number of those who are actually aware of their disease, and these are the high estimate is in red and the low estimate is in blue, only about a quarter of those individuals who are actually infected are aware that they have the disease. And the numbers just keep on getting smaller. If you look, the number of entering into care out of that 2 million, it's about 200,000 entering into care, and the number of those who are actually receiving prescription, it's only about 50,000 individuals. So this is a really large drop-off, and so I think we really need to work harder to do better to get people into treatment to stop some of the unnecessary morbidity and mortality from hepatitis B. And so about 15 years ago, we started a hepatitis education and prevention program in Chicago. And over the course of this time, we have probably educated over 50,000 individuals and have done thousands and thousands of screenings. And this program has been continuously funded since 2008 by really generous grants from the Centers for Disease Control and Prevention. And in 2012, we were awarded again another cooperative agreement to conduct hepatitis B surveillance and screening in the Chicago metropolitan area, and really took this opportunity to try to understand how we make sure that there is an appropriate linkage to care, and how do we identify really at-risk populations. And so this data, which we wrote up in a publication, which we'll talk about next, represents kind of that work. And so if you look, we screened about, in this time period, we screened about 1,100 individuals. And overall, we had about 6% that were positive, as evidenced by surface antigen positivity, which is the marker that we look for. And about 18% had evidence of previous exposure with the presence of core antibody. And in terms of our screening, about 13 the majority came from Africa, China, or Laos. And you can see across the chart in green, you can look at the number screened and then the percent positive. So the highest percentage of positive, meaning surface antigen positive individuals, came from China, Africa, and Laos. Okay, next slide, please. Maybe I can do it. Oops. Okay, so the paper that we wrote is what I want to focus on now. It was a comparison of linkage to care in clinical and non-clinical settings. And because marginalized communities, particularly Asian and African immigrant communities, for example, these communities are very difficult to reach. They often have language barriers and may live in ethnic enclaves, have many other problems that make linkage to care challenging, including the lack of culturally competent services in the healthcare system. So we really wanted to ask the question, can non-clinical settings be as effective as clinical settings in reaching, screening, and linking Asian immigrants to care? And we really felt like this is an important question because a lot of data suggests that community-based screenings can be very effective in terms of number of screening, but that linkage program often causes challenges. And so the way we define screenings in non-clinical settings, we looked at health fairs hosted by both faith-based and community-based organizations. And we really looked at those as opportunities for language concordant outreach and ways that we can lessen perceived stigma and financial concerns by going into the community. We define screening in clinical settings as those in community health centers or federally qualified health centers, free clinics, small group practices, and hospitals that provided direct access to primary care physicians and preventative services. And again, our hypothesis was that we could create a system where non-clinical settings may be more effective in hepatitis B control, and facilitate outreach of hard-to-reach populations in potentially larger numbers than in clinical settings. Next slide, please. So what we did was we wanted to make sure that we were able to design and redesign systems within our partner healthcare centers as well as the community sites. So in the healthcare centers, what we did was we created a hepatitis patient navigator, and those were assigned to each of our participating sites. And they would be responsible for notifying individuals of their results, to vaccinate susceptible individuals, and to provide some case management for those who are found to be surface antigen positive, which included referrals for additional lab testing, referrals to specialty care, and to assist with navigational services. And again, this was done within our partner healthcare systems. At the community site, we worked with healthcare workers, and they provided culturally relevant education. They encouraged screening at health centers or at free clinics. They were helpful in notifying patients of screening results, particularly in languages specific to the communities that we worked with. And they also were able to refer patients to local providers and interface with our hepatitis navigators in the hospital. And so in essence, our community health workers and patient navigators worked together to ensure patients were scheduled and to make appointments. So this was really what our model looked like. We had primary care providers on one side and community-based organizations on the other side, and we're really determined to figure out a way that we could link these two. We work a lot with community health workers, which we know have really large impact in the community, and yet when it came to entering the healthcare system, they were just as lost as those that they were trying to help. And so what we wanted to do is, at the same time, the hospitals were really great at delivering healthcare, but they sort of got stuck when they wanted to reach into the community. And so we had a community placed navigator into the healthcare system so they understood the system, and then they could interface with our community health workers. So there was, they had reciprocal site and facility visits. We provided cultural training for these groups. We provided training for both hepatitis education and linkage to care mechanisms. Next slide. And what we found was that twice as many Asian Americans were screened in non-clinical settings compared to clinical settings, which didn't really surprise us because we knew that would happen. We also found that there was no significant difference in the percent of individuals that were found positive for hepatitis B, gender differences, insurance status, or years in the United States. And this is an example of screening sites and across the different settings. So our clinical settings, there were 3 federally qualified health centers or small clinics that enrolled individuals for this process. And you can see the different non-clinical settings, anywhere from faith-based organizations to community-based organizations that were involved in this study. In terms of patient demographics, you can see that about 30% of our patients were from clinical settings and almost 70% were from non-clinical settings. So 229 from clinical settings and 530 from non-clinical settings. And if you look at the different demographic characteristics, about 62% were women. The majority that we screened, 82%, were Asian. There was a pretty fair spread in terms of age distribution between the ages of 40 to 69. 14% had lived in the United States for less than 10 years. We had quite a bit of missing data in this one area, and about 50% were uninsured. What's important to know is that about 90% said that English was not their primary language. So again, this is a population that is very difficult to reach without the help of the community. What was most interesting is looking at the number of positive individuals in clinical settings versus non-clinical settings. What I think is really important is to look at that one area circle in the middle of the screen, and that is the number that were referred to medical care. And what we found was that, interestingly, what was statistically significant was that those individuals who were seen in the non-clinical setting, 77% went on to be referred to medical care, compared to 56% that were seen in the clinical setting, which doesn't make sense. It surprised us, but it really highlights the importance of developing a process that allows non-clinical screening to have really positive outcomes in terms of follow-up care. And so what we found was that there was really no significant association between the number of demographic factors and between sites, that those in the community really looked like those that were being seen in the clinic. We also found that screening rates were higher in the non-clinical sites, but most importantly, we found that in our cohort, referral rates were significantly higher in the non-clinical setting. We also found that non-clinical settings do have the capacity to reach a larger segment of underserved foreign-born populations who tend to be uninsured and have limited English proficiency. And lastly, we reported that this program demonstrated the merits of using a community-based patient navigation model for linkage to care and to provide infected individuals with access to culturally competent medical care, that this actually can happen in a non-clinical setting, which I think will be leading in a second to our next speaker. In terms of acknowledgement, again, I really want to acknowledge the CDC's Division for Viral Hepatitis, and in particular, Dr. Aaron Harris, who is our program officer for this grant. He has been really very helpful in helping us think through this data. Members of the Asian Health Coalition, so Aliyah Ryan, Sharon Sung, Angela Forfia, Matt Johnson, and Edwin Chandrasekhar. Really, this is a multi-partner effort. So our clinical partners from TUI Health Centers, Dr. Kaufman, and Heartland Health Center, Dr. Friedman, were really instrumental in having in the ability for us to provide education to providers, as well as thinking about this unique hepatitis navigator model. It really required some buy-in from the healthcare system. And the University of Chicago Center for Asian Health Equity, for Nessa Randall and Michael Quinn, who have helped with the data evaluation and design of the study. Thank you, and I look forward to questions at the end. And Jane, I'm interested in hearing what you have to say next.
Great, thanks so much. And we'll turn it over to Jane.
Hi, good afternoon, everyone. Thank you, Kate, for inviting us to share our work at HBIDC. I'm going to first go over our guidebook to prevent hepatitis B, and then I'm going to share our work at HBIDC. Okay, so the guidebook was developed and finished in 2007 in collaboration with It's 3 organizations. It's HBIDC, Actual, and the Health Forum. And it's from the funding through the OMH. Next, please. And the goal of the guidebook is, the main focus is to encourage the community leaders to take ownership to develop the health prevention program and to specifically tailor to their needs. And then also provide leaders and the outreach workers with talking points for the hepatitis B. And then also assisting the organizing with the educational screening and the vaccination events. And it has a lot of forms. It has everything that you need to know about how to do the campaign. Next slide, please. So there's a few slides that I believe that Kate has it in the handouts if you'd like a copy of this guidebook. But when I first started with HBIDC in 2009, it was like a Bible for me. And it has everything one needs to know how to do a education screening and vaccination event. From building trust with the community and the religious leader, volunteer training, and the steps to organize an event. Next slide, please. This guidebook is especially helpful when they if you need the forms, registration forms, volunteer training forms, volunteer forms, HIPAA regulations, and over the years I have improved some forms, but please feel free to contact me if you need any help with these forms. Okay, next slide, please. And so 2016 has been a really great year for us. We celebrate our 10th year anniversary. Next slide, please. And then we also received a White House Viral Hepatitis Testing Appreciation Award. Next slide, please. So 2016 has been really a great year. We had screened over 2,373 people for hepatitis B. And we started screening hepatitis C in 2013. And then also in 2016, we were on the project with the University of Maryland, and that funding comes from the HIV. So we had to screen HIV. But we did screen 1,500 HIV. And we ran about 56 total events in 2016 and reached out to over 50 different countries. And the hepatitis positive was 3.5%, hepatitis B positive was 3.5%, and we also used the hepatitis B surface antigen to determine that. And we did hepatitis C, we used the rapid testing, and then if the person tested positive, then we will do a quantitative RNA for hepatitis C. And the positive for hepatitis C is 2%. And there was only 2 people tested positive for HIV in our community. Next slide, please. And out of the total screening in 2016, majority of it is the Asian population. And then there's the African populations, and African populations from Nigerian, Ethiopian, Cameroon, Ghanaians, and many different small countries. And then also the Asian population is the Chinese, the Cambodians, the Mongolians, the Vietnamese, and the Koreans. Next slide, please. So although our Hep B positive was only 3.5%, but that is when we got the aggregated data. But when we disaggregated the data, the Chinese was tested 10% positive, and the Vietnamese is 5%. The Mongolians were tested 5.2% positive for B, 8.5% tested positive for C. The Ghanaian is 7% tested positive for B, and the Cambodians is 13.7% tested positive for B. So when it's desegregated, the data looks very different from each country. Next slide, please. So since I started working with HBIDC in 2009, and you see the screening numbers is, and this is the data for the screening numbers, the education in the screening and the positive, and it's very, it fluctuates, and the fluctuation it's because of and it really directly reflects on the amount of funding we received that year. So 2016, we were on a few projects. One big project was with the University of Maryland, and so we did screen a lot of people and educated a lot of people in 2016. Next slide, please. And then the hepatitis C, we started screening in 2013. And again, that also reflects on the number, the amount of funding that we received in that year. And then the next slide, please. So overall accomplishment in the 10 years is we did over 11,832 hepatitis B screening. and 5.1% tested positive for B, and then we did 5,732 for hepatitis C screening since 2013, and overall positivity is 3%. Next slide, please. So I'd like to share with you a video that we had created in one of the screening event, at the Mongolian screening event. And the, okay. Okay, do you have the sound? Okay, I don't hear the sound. Do you hear it?
The goal is always to screen, to diagnose, and then link patients to care. Now that we have curative therapy, there's a lot of focus on let's get more people into treatment. But the root of it all is really with screening. The next steps after someone tests positive for hepatitis C at one of these screening initiatives is that they're linked to care wherever it's geographically appropriate for them. In modern day hepatitis C treatment, we have cure rates over 90%, so the vast majority of people who are started on treatment, who are able to get that medication, will be cured of this disease.
Hi, my name is B. I had Hep C when I came from Mongolia 3 years ago. I was very sick and weak, and I was unable to take care for my child. Fire connected me with HPIDC, and with their help, I got cured.
Over 300 people were screened very successfully, very professionally, and I believe all of the clients left with a little bit more information than they came with.
Hopefully, such efforts will continue, and we will be able to educate people more about the disease and increase awareness in the community of the hepatitis and HIV infections.
Thank you, HPIDC. Thank you, everyone who helped me to gain my health and life back.
So at that event, 304 people were screened, and 16 tested positive for hepatitis B, and 26 tested positive for hepatitis C. And so we are still working very hard to link everybody to care. Some of the Hep B positive, they are co-infected with hepatitis delta, and that's it's even harder to treat. So a lot of these co-infected patients were referred to NIH. And there's like 3 or 4 people that's been cured from hepatitis C that we heard, and so that's very rewarding and very great news. The person that you saw on the B that you saw on the video was tested positive for C, and she's been cured. But when she was very sick with hepatitis C, her baby was actually been taken away by the family services because she was not able to take care of the baby. The baby was crying so much, and the neighbor complained, and the police came, and the family services got involved. And so now she's been cured, and she got her baby back. So that's that's very good news. Well, thank you very much, everyone.
Thanks so much, Jane. That was an amazing event. Over 3,000 people. Just shows the power of community-based screening, as was found in Dr. Kim's presentation. And so this is just a reminder that we'll begin our question and answer period. So please feel free to ask any questions via the chat box, and I will read them out to our presenters. So we did have a few questions that came in during the presentations, and I think we'll start with Dr. Kim. And this is a clinical question. Dr. Kim, the question is, does hepatitis B ever resolve without treatment?
That's a good question. So there about 0.5% of individuals will spontaneously revert from being surface antigen positive to being antibody positive, which means that you are effectively have gotten rid of the disease. It's not common, but it can happen. But because it's so uncommon, we usually want to really follow individuals very routinely to see if either this happens or at what point they may need medication.
Got it. Great, thank you. Our next question is related to the study and the community screening part. The question is, were children ever included in the community screening?
Sorry, is that for me or for Jane?
Yes, you both could answer it. I think it came in during your presentation, but Jane could answer it too. You want to go first?
So for our group, we have, in terms of thinking about individuals that are children, we have tried to stay away from screening children. It's just a little bit more complicated because most of our models are really working only with adults, and our consent really looks at those that are over 18. Having said that, we have, because we go and do a lot of immunization for those who are susceptible, many of those end up being children, and before we provide immunization to children from immigrant families, we always screen them. But I would say that over the course of 15 years, less than 1 or 2% of the people that we have screened have been children.
Okay, thank you. Jane, would you like to address that?
Yeah, sure. That is the same for us too. We try to stay away from screening children because we had a really bad experience. But because the parents want the child to get the blood drawn, and then the child really wanted it, and so that child was screaming and crying, and so it created such a bad scene for us. So we try we try to stay away from it. But if in some cases, like the immigrant family, the child like 14, 15 years old, they just arrived from the country with a high prevalent rate. And so what we do is we directly ask the child and say, do you want to be screened? And it's going to be a blood drawn, and you're going to get pricked. And are you all right with it? And if they agree, and if they say yes, we'll do it. But we unlike Karen, we try to stay away from it and just and say, it's 18 and over.
Great, thank you.
Another reason I would say that we have stayed away from children is most of our providers that we link to care are not pediatricians. They tend to be adult primary care providers. So it just makes it very challenging otherwise.
Mm-hmm.
Yes. Mm-hmm.
Thank you. So related to immigrants and recent refugees, there was a question that came for Jane. Does HBIDC have overseas partnerships? And then there's a sort of a follow-up to that related to that question. If you have advice on how international organizations could obtain funds to screen, and this question came from Uganda.
Mm-hmm. We're just a local. We are a local DC metro area. We haven't gone out to international. So it's not on our agenda right now at this point.
So can I pipe in there? So we also in Chicago do a lot of work with the African immigrant community, and as I stated that this is a population that's extraordinarily high risk for not only hepatitis B but liver cancer as a result of hepatitis B. So while so in terms of the World Health Organization, many countries now have adopted hepatitis B vaccine. Many of countries in sub-Saharan Africa are included in that. The problem is the implementation of that process is very expensive. So even if there is a policy to advocate for hepatitis B vaccine for children, it may be cost prohibitive. And so I know that the Gates Foundation is very, very interested in childhood immunization. And so if you're thinking of kind of international funding, that's usually the foundation where we look for to think about funding partners overseas.
Thank you. Our next question is related to screening, I think community-based screening. What labs do you draw for screening? Or what labs do you send your screening samples to, maybe?
For HBIDC, we use LabCorp and Quest.
We screen using hepatitis B surface antigen, hepatitis B surface antibody, and core antibody. They tell us all different things. We, in the past, had not been looking at core antibody, but once we started working with the CDC, they really wanted us to look at that because then they could get an overall idea of previous exposure and prevalence. So those are the ways we screen, and we use mainly Quest Lab.
Got it. Thank you.
I'm sorry. We do. Kate,
sure.
We do hepatitis B surface antigen and hepatitis B surface antibody. So we don't do the core antibody. Just the two. We just do the two testing.
Okay. Our next question is, are there many or any pediatric liver specialists that work with children in the U.S.?
There are a lot of pediatric gastroenterologists, and also the other group that often works a lot with children are the infectious disease people. And hepatitis B more and more is being treated by primary care, so we're hoping to also include med-peds individuals that would have capacity to treat hepatitis in children. I would have to say that a lot of people, when they're found to be infected, don't necessarily fit guidelines for treatment, and so sometimes it's a wait and watch. Depending on sort of what their overall serologic status is and their viral load.
Thank you.
And in our area, it's Dr. Catherine Schwartz at the Hopkins. Mm-hmm. At Hopkins, she specializes in pediatric hepatitis.
That's right. So Jane, related to the event where you screened, I thought the Mongolian community, 300 people. A fellow partner is asking, how many hours was the event?
It was over 4 hours.
Oh, great.
We had 10 phlebotomists.
Wow. Okay. Thank you. And for both of you, this is a general question. How much does a hepatitis B surface antigen testing cost?
So I think what we have sort of a bundled payment. So we have kind of worked for both surface antigen, surface antibody, and core antibody. and it costs anywhere between $20 to $25 per person. But we have not unbundled it as just a surface antigen.
For us, we do the surface antigen and antibody, and it's $15 for both.
Got it. Thank you. Well, you had both mentioned working with immigrants in the community-based setting and also in the federally qualified health centers. The question here is, are immigrants offered the hepatitis B vaccine?
So the question may be looking at the difference between immigrants and refugees. So actually people who have refugee status who come to the United States have access to a comprehensive health assessment as part of their refugee status and have the ability to access health care. And within that comprehensive health exam, they also include hepatitis B screening. And what I'm not sure about, and that's a good question, what I don't know is if they're found not to be hepatitis B positive, but are susceptible to hepatitis B, I don't know that they are given immunization if they're an adult. So that I'm not sure about. That's for refugees. For immigrants, as you probably know, for immigrants that don't have refugee status, when they come to the United States, if they have no insurance, it takes 5 years before they're eligible for any type of real insurance. And so this is a population that we often pick up in our community screenings because these are individuals that otherwise would not have access to care. And for our programs, we do not, the screenings that we do are free, so we do not charge our participants to get screened. And what we do is those that are susceptible, we try to work out a linkage program to make sure that we can immunize those family members that are found not to be positive because they may be living in a household where they're at high risk.
Right. So, oh, sorry, Jane, go ahead.
We had experienced that in 2014, we screened 1,000 Burmese, and a lot of them have gone through this refugee process. And when I spoke with the Maryland Department of Health, that's what we were going to do. And so the hepatitis coordinator at Maryland Department of Health told me that, Jane, these refugees, they've already gone through screening, hepatitis B screening, and also vaccination, so you won't find anybody needs vaccination, but we were already starting the project, but after we screened close to 1,960 something, 60 somewhat Burmese, and we found 29% of the Burmese is vulnerable and needs a hepatitis B vaccination. So what we found out is the refugee process, they give them the first shot, and they might give them the second shot, and they follow them for 3 months. But with the hepatitis B vaccines, it's a duration of 6 months. So we think that what happened is once they, gone out to the community, and then they started to start working, and they won't go back for their third shot. Mm. So there's still a lot of the refugees is still not 100% protected.
Okay, thank you. So for both of you, in the community-based screening settings, what was the most effective strategy at getting people to attend the screening events?
In Chicago, the most effective strategy for us has been through broad partnership with our community-based organizations who have community health workers and have access to ethnic media. It's been really important that we go to the community to help them empower them with information that allows them to advertise for the events, and then also to find a location within the community that is has high traffic.
Okay.
So what we have found that's very enticing for the community is we include a glucose and a cholesterol screening with the hepatitis screening, because nobody likes to come and test for the hepatitis. But when we said glucose and cholesterol, and they a lot more people was interested. So that's what we do, is to include the glucose and the cholesterol. And in some community, we even include a chemistry 14 testing.
Thank you. And for Dr. Kim, so you had mentioned from your findings that the linkage to care piece was that you found a higher percentage in the non-clinical setting. Can you explain why that is in terms of compared to the clinical settings? Was it like in the clinical settings, was it just a matter of referral to a specialist?
Yeah, that's interesting. So I think the percentage of individuals that were actually successfully moved through the system, I think, was a combination of two things. One, I think that we had really well-versed community health educators that we have been working with for a long time, so they understood the system. I think the other thing, and those community health workers are very active in reaching out to the patient for follow-up. So it's kind of almost like a function like a community patient navigator. The other thing is that we linked the community health worker with a patient navigator who was placed in the hospital that we trained as the community. And so this allowed there to be sort of this natural communication and interface that wasn't there before. So I think that was really important. In terms of the hospital doing their own thing, I mean, I think the hospital that we worked with federally qualified health centers and a health center that sees a lot of refugees. And so I think the ability to follow up once you get, even if you have a clinic-based screening, there's probably not as much effort to reach out to those people from the healthcare system as there would be from a community health worker in the community being able to continue to call an individual. So I think it's just access to that person. The health systems that we work with, even though they're extraordinarily dedicated to taking care of kind of the poor and underserved and marginalized populations, they don't have the same capacity that the community would have in making multiple phone calls. You know, think of how often your hospital calls you to ask you if you're coming to your appointment. I mean, you might get one call and it may be in English, and if you don't speak that language, you might not get that message. So I think having that bicultural, bilingual linkage is really important.
Right, makes sense. Thank you. So our next question is a general question, as we've been talking a lot about immigrant communities. So sort of a one-on-one, why is Hep B so prevalent in the Asian and African communities?
Well, so similar to how hepatitis C is just really sort of endemic in the United States, it's extraordinarily common. I think that's the same thing that happens, and we don't quite know why there is such a heavy concentration of this disease within these populations. That we do know that once there's sort of an epidemic proportion of disease, it's because hepatitis B is so highly infectious. It's extraordinarily easy to be passed on. And the way it's passed on in the United States is very different than the way it's passed on in Africa, for instance, and Asia. So in this country, it's largely a sexually transmitted disease, where you may have a relatively healthy immune system. And if your immune system is healthy, you may have a very low risk of actually developing chronic hepatitis B. In places where it's very high prevalence, like in Asia and sub-Saharan Africa, the transmission is during the birthing process, not transplacental, but during the mixing of blood during the birthing process. And when you're a baby and an infant, your immune system is very, very weak and still developing, and it's unable to kind of stop this virus from kind of invading your system. And so when you come from a country where it's very high prevalence, it just keeps getting passed on to mother to child. And those children grow up to have chronic disease because they have a weak immune system, and so the chance of them developing chronic disease without immunization or treatment is 90%. So it's almost mirror opposite of what happens in the United States, and that just gets passed on and on and on. And where we can stop this is by active immunization, which can prevent the spread of this disease.
Great, thank you. Our next question is for Jane. So you had mentioned that you a strategy to get people to come in to be screened for hepatitis B. You offer, for example, cholesterol screening. How do you get funding for cholesterol screening?
We don't. We don't. So what we do is we use some of our marketing funding, to cover the cost of the screening. Yeah. Yeah. So we try to get some free marketing services on the TV, the ethnic TV, and an ethnic newspaper to write a news article, and then try to do use some of the marketing budget to do and some people come and just say, no, I don't want to have B, I just want glucose and cholesterol,
Right.
Then we will say, no, it's a package. You have to get screened for hepatitis.
So we have time for one more question here. And okay, it looks like our last question is about tools that you use for both clinical and non-clinical settings. So the person is asking if they could get examples of data tools that you used for clinical and non-clinical setting to provide Hep B services.
Yeah, we could definitely share the data variables that we collect. I don't know if that's, and if this is not really what you're asking, continue to ask Kate questions, and we can go offline and make sure that we have what you need. But yeah, so things like electronic medical record prompts for hepatitis B for those who are susceptible, which data variables you might want to collect to be able to help with this process, how you do implementation of screening in either clinical or non-clinical settings. That's information that we could certainly share. And recently we created a hepatitis navigator toolkit, and we can send that. And I think, Jane, I'm sure in your beautiful work, you have sort of a cookbook of how to approach screening. So I think that there's a lot of tools that can be shared.
Sure, it's all in that guidebook that Kate has got.
Your Bible.
Yes. Yeah, my Bible.
Great, thank you both so much. So if you are online still, you should have been able to click and download both the journal article that Dr. Kim presented, as well as the HBIDC guidebook that Jane presented. And we will provide both of those, links to both of those again once after the webinar, along with a copy of the PowerPoint presentations as a resource. And if we weren't able to get to your question today, or if you would like to ask any follow-up questions, as Dr. Kim said, please feel free to email us with your follow-up questions or any additional questions that you have for our presenters, and we'll be sure to get back to you as soon as we can. And I wanted to just say thank you again to our presenters, Karen Kim and Jane Pan. Thank you for your time and for the incredibly rich presentations. And thank you everyone for participating today. Please do look out for an email from us within the next few days. And as I mentioned, we'll include all the materials from today's webinar, so it'll be easy for you to share with your networks. And as you exit the session, we'd greatly appreciate your feedback on a short survey, so that we can continue to provide information that you need and improve our webinars moving forward. So thank you all again, and have a great rest of the day. Thanks, Karen and
Thank you.